Okay, our next speaker is Dr. Priscilla Hsue, who's now the chief of cardiovascular disease at UCLA, having recently moved there from UCSF. Um, while she was at UCSF, she was really one of the pioneers, and I think one of the first to ever have a cardiovascular clinic for specifically people with HIV, working not only on the clinical treatment of people, but doing a lot of the basic science investigations with colleagues like Steve Deeks, Peter Hunt, uh, Jeff Martin, others at UCSF, and really looked at the roles of inflammatory markers and inflammation in general as a causal pathway to advanced cardiovascular disease. So I can't think of anyone better to really give us an overview on what's new in 2024 for the prevention of cardiovascular disease in people with HIV. So Priscilla, welcome, and you can share your slides with us if you can.
Great. Thank you so much for that really kind introduction, Michael. And just I want to do a sound check. Can people hear me?
Yep.
Are slides looking okay?
Yeah, we hear you and we see your slides. I think we're good to go.
Wonderful. Well, I'm so honored to speak on this topic today, strategies to address CV risk among persons with HIV. I guess I should really look forward, 2025 and beyond, where will we be? These are my disclosures. The learning objectives for today will review some of the data on integrase inhibitors and CVD. And then we'll also review the strategies to reduce cardiovascular risk. This is really going to be on top of statin therapy in the setting of HIV. And we'll look at strategies to address inflammation. And I think the one disclaimer here is I'm not going to be able to wrap this up in a very neat bow for everyone because the field is rapidly changing. There's lots of unknowns, but I think we'll review a lot of the data and we'll have a lot to think about at the end of the talk. So what about the global burden of cardiovascular disease and HIV? And this is a meta-analysis that was published in 2018. And what's interesting here is that persons with HIV are twice as likely to develop cardiovascular disease. In the past 20 years, the global burden has actually tripled. And I think what's interesting is there's not a one-size-fits-all to cardiovascular disease with HIV either. You can see in developed countries, it presents more as atherosclerosis, and in resource-limiting settings, it is more like a myocardial fibrosis, potentially heart failure with preserved ejection fraction. And as a cardiologist, when I look forward to cardiovascular disease in the general population of the United States, this is a nice, interesting, kind of scary prediction here. We see that traditional risk factors in the general population, hypertension, diabetes, and obesity are going to increase significantly along with all of these cardiovascular issues. And it's estimated from this advisory from the AHA that in 2050, cardiovascular disease will impact 45 million individuals, and cardiovascular disease and hypertension will impact over 184 million adults. So that is really sobering. So the outline for today's talk, I had mentioned, we'll touch on integrase inhibitors, lipids, blood pressure, and inflammation. And I want to look back at, some of the studies in the general population. So Jupiter, to remind everyone, was in the general population in which rosuvastatin significantly reduced LDL cholesterol by 50%. There was also a significant reduction in inflammatory markers, as well as a 44% reduction in the primary endpoint. And so, I think early in the field, some of us thought that, well, HIV should be a risk equivalent with respect to statin use like diabetes, but we didn't really have the evidence to change guidelines. And so with that in mind, we had the clinical trials. And here, I think as most people on the call know, last year there was the pitavastatin study in HIV called REPRIEVE, showing that pitavastatin significantly reduced LDL cholesterol as well as clinical events. And based on this study, statins are now indicated for most individuals with HIV over the age of 40. So I'd like to go to an audience response question. So we have a patient who's seen you in clinic. He's 55. He has high blood pressure, is on medication. He is, recently started a statin. His LDL is 120. He's on an integrase based regimen, no prior cardiovascular disease. And he's asking you, doctor, will being on this integrase inhibitor increase my risk for cardiovascular disease? So I want to ask the audience, yes, definitely, definitely not, or I'm not sure and confused. And so I'll give a little bit of time here to vote. I'm going to shut the poll and then let me try advancing, and I hope this works. Okay, so 60% of people are not sure and confused. So let's try to draw some light on that. Okay. So new drugs for HIV, does this equate to new problems? And some of the initial studies looking at INSTIs and cardiovascular risk, this is a market scan database looking at insured and Medicaid individuals in the United States who are initiating antiretroviral therapy. And in this study, interestingly, integrase inhibitors versus a non-INSTI regimen was associated with a lower risk of cardiovascular disease. So that is interesting. That was published in 2020. However, since that time, other studies have come up, and this is the RESPOND cohort, which is kind of the newer version of DAD. And here, similar to the abacavir story, they found that kind of integrase inhibitor use in the first 6 months, as shown here, was associated with a doubled risk of cardiovascular disease. You can see, however, with time, this goes away. We're not really able to tease apart why this is in this study. However, after that, there were other studies that showed no difference in cardiovascular risk. This is data from the Swiss cohort study, antiretroviral naive individuals. And in these diagrams, you can see there was no difference in either short or long-term cardiovascular risk among individuals who started integrase inhibitor regimens compared to those on other regimens. And this was both in unadjusted and adjusted analysis. So I want to bring up the idea of a target trial emulation, because this is something we'll be hearing more about or more recently. And so what is this? We know that RCTs, of course, are the gold standard to, assess the efficacy of an intervention. However, they take a lot of time. In some cases, they can be unethical. And so, you can use what's called a target trial emulation, which is to use an observational study to look at the evidence of an intervention. You can kind of specify the protocol. But of course, this kind of study is always susceptible to confounding. So using this target trial approach, this is data from an observational cohort, HIV causal and ARTCC in Europe and North America. The study showed that the initiation of integrase inhibitors was not associated with cardiovascular risk. This was shown in both antiretroviral naive as well as experienced individuals. So I think when we go back to this patient case, I agree with you. I'm going to say here the data is kind of a little bit all over the place. And I think, conflicting studies, different cohorts, different study designs. And I think time is going to tell here. There's going to be longer studies with more data, or else there may be a shift to newer HIV medications that have different side effects. So another question. I'd mentioned the REPRIEVE trial. Does this mean that everyone with HIV should be on pitavastatin? So I'm going to say yes, no, maybe. Okay. So I'll give you a second to vote. And I'm going to try to advance. And so here, interesting. Okay, great. So we have 56% said no, 30% said maybe. So let's think about this. All right, excellent. So what was a REPRIEVE? And I'm going to just go over this quickly because I think most everyone knows this. It was a large outcome-based study among asymptomatic individuals who had with HIV with a 10-year risk that was less than or equal to 15%. They were randomized to pitavastatin versus placebo, driven by clinical events. And the outcomes are shown here. You can see a significant reduction in cardiovascular disease, as well as cardiovascular disease and death. And I wanted to look at, in the general population, how do we figure out who needs statins? And of course, this is based on the calculated ASCVD risk and the number needed to treat. And so the lower the number needed to treat, of course, the more benefit of the intervention. So we can see here for statins that individuals that are recommended to be treated should have a number need to treat around 40 to 60, and this calculated risk around 10 to 20%. So what was the number need to treat in REPRIEVE? And we can see overall, it was 106. I think they published a follow-up on this to show it was slightly less. But of course here, one size does not fit all. So you can see if you had a predicted risk that was higher, so more than 5%, you had a much better benefit from the medication. And those who had a lower calculated ASCVD risk, the benefit was a bit less. So we can overlay that into our diagram here. The overall reprieve result was in this green, which is probably, benefit not as clear. However, if you look at individuals who have a low cardiovascular risk in reprieve, their benefit was much less. And individuals who had a calculated risk 5% above had a significant benefit. And so if we use those thresholds in existing statin guideline therapy, only individuals with HIV who had a calculated risk that was 5% higher would be recommended by statins. And in fact, the new guidelines were released earlier this year that among individuals with HIV who are at low to intermediate risk above the age of 40, if your risk is between 5 to 20%, a moderate intensity statin is recommended. If your risk is less than 5%, you can think about it, but just remember that the absolute benefit is modest. And there's really not enough data among individuals who are less than 40 years old. I want to remind the audience, what are the guidelines for the general population? And that is, so outside of HIV. So if you have known cardiovascular disease, you should be on high intensity statin. If you are between the ages of 20 to 75 with a high LDL above 190, you should also be on high intensity statin. And if you have diabetes, you should be on moderate intensity statin. So back to our audience response question. So I'm going to agree with the audience here. So I'm going to say not all persons with HIV, but certainly it should be considered among individuals between the age of 40 to 75 who have a calculated 10-year risk between 5 to 20%. So if you use that risk calculator in HIV, does this mean you will not benefit from statin at all? And I think what's a bit confusing is that is not the case. And there have been studies from our team and others to show that even if you have a low calculated risk, you may have evidence of significant atherosclerosis on imaging. And in fact, using CT angiography among individuals with HIV who had a low risk, around 30% had evidence of atherosclerosis. So I do think something to consider in the field in the future is if there is someone that you may be on the fence about, you could consider imaging to think about individuals who are at that, in-between risk for cardiovascular disease and starting a statin. So post-reprieve, what's next? Individuals, most age 40 and above, will be on a statin. However, I want to point out in this trial, 40% of individuals had an event while on a statin. Thus, there's initial need for risk reduction aside from statin, and particularly the need to address inflammation. We should think about which therapies should test it in HIV, strategies to improve access and compliance, things that we know work in the general population with cardiovascular disease, but are not routinely used in HIV, like injectable medications to lower cholesterol and colchicine. And these anti-inflammatory approaches, of course, may also impact comorbidities and cure. So here, what are the opportunities for improvement in statin use? And this is a study that was done in San Francisco showing that, looking at patients in clinic. So among those who had a cholesterol, around 43% were eligible for statin. But interestingly, of those percent that were eligible, less than half were actually on statins. And so I think, reprieve results, important reminder to all clinicians to think about statins, even in persons with HIV, to think about that criteria, because this was before the reprieve study. And even before that, individuals with HIV were undertreated. This is another study to illustrate the statin gap. And so from NA Accord, you can see the guidelines change in around 2014. And here, a large percentage of individuals with HIV were eligible for statins, and only a small percent, here less than 20% of persons with HIV were actually initiated. So you can see here criteria that are associated with being less initiation of statins, including smoking, Black, Hispanic race, more advanced HIV disease. So of course, 2024 now post-reprieve, how is that statin gap going to change? So we know the statins are beneficial, but will in persons with HIV get the statins, will they take them and will they stay on them? What I think is very interesting in the general population, less than half of patients who are eligible for statins get them. And then among our most highest risk patients, so those are patients who have cardiovascular disease, 50% of them are not on statin. And to that end, remaining and taking statin for a long period of time is low. So after 5 years, less than 25% of individuals with cardiovascular disease are on statin. And indeed, kind of similar studies have been done in HIV to show that the persistence and adherence to statin doses use is low. And moving forward, will that access to statin and adherence impact persons living with HIV? And of course, here there are many barriers to achieving a low LDL cholesterol. And this can be, kind of considering the side effects of statins, polypharmacy, physician time constraints. And so there are approaches designed to increase access, and you can consider kind of an aggressive strategy up front. So this is a study done in the general population that got a lot of press this year, and it was kind of taking the physician out of the equation, but having over-the-counter access to statin. And it was a web-based application to be able to provide non-prescription access to statin. What was interesting is the users, so the patients, were able to correctly self-select for statin use. And using this approach, there was a significant 35% reduction in LDL cholesterol. We as a field, can we leverage the success from injectable ART to improve adherence and access to other like preventative interventions? And I want to, highlight the thought of injectable lipid lowering in the setting of HIV infection. Inclisiran is a silencing RNA agent that is a twice-a-year injectable. There's significant LDL reduction. It has been studied in, many individuals and is now being looked at in outcome studies. Want to think about, is there a role for injectable lipid lowering in the setting of HIV to improve adherence and decrease pill burden? And in fact, using this approach in the setting of the general population among individuals who had cardiovascular disease on statin, an upfront inclisiran first strategy led to a 60% LDL reduction versus usual care. And of course, they are now doing outcome studies in the general population. What about injectable agents for blood pressure? And this is zilebesiran, which is a 6-month injectable medication. You can see here there's significant both systolic and diastolic blood pressure lowering using this approach. And so looking forward in the setting of HIV, will we have injectable medication for HIV, lipids, and blood pressure that will be like twice a year? So how much lipid lowering do we need? Are statins going to be enough? Will we need other options? So this is a focus on pitavastatin. If you have cardiovascular disease, pitavastatin is clinically indicated, true or false. Pitavastatin is cost effective. And in the past 20 years, I've prescribed pitavastatin how many times? I'm going to just move forward in the interest of time. So I want to highlight that pitavastatin is a moderate intensity statin. And that is in contrast to high intensity statins like higher dose atorvastatin and rosuvastatin. And so these high intensity statins should be used for treatment of cardiovascular disease as well as high risk primary prevention. And in this study that was done before Reprieve was published, they compared the cost effectiveness of pitavastatin to pravastatin in HIV. And I think not surprisingly, pitavastatin was not cost effective. However, there's some changes in the horizon that may change this moving forward. So back to our true and false. If you have cardiovascular disease, pitavastatin is indicated. That is false. It's a moderate intensity statin. And if you have high risk, high intensity statins like high dose atorvastatin and rosuvastatin are indicated. Pitavastatin is cost effective. I'm going to say currently no, but this may be changing in the future. And in the past 20 years, how many times have I prescribed pitavastatin? I've actually never prescribed it. So we'll see how this changes. So I want to focus now a little bit on inflammatory risk. We know in the general population, this is data from lipid-lowering agents, that individuals who achieve the best clinical benefit lower both their LDL cholesterol as well as their inflammatory markers, as shown here in red. And kind of based on this, it's thought that, well, if you're at high risk and have cardiovascular disease, everyone should be on high intensity statin. However, some individuals may benefit from additional lipid lowering, additional anti-inflammatory agents, or both. Let's look at the cholesterol question. So there is something that's called residual inflammation, and that is among individuals in the general population. You can see here that a lot of them, 29%, have residual inflammation, 14% have high cholesterol and residual inflammation. So that's around 44% in both of these studies that we're looking at lipid lowering in the general population. And so you can say, well, what about using our best lipid-lowering agents? Is that residual inflammation still present? And this was recently shown at a roundtable. And you can see here that even using our best lipid-lowering agents, injectable agents, that residual inflammation as well as residual cholesterol risk remain common in the general population. It's again over 44%. So I want to think about the LDL goal we should target in the setting of HIV infection. Should it be less than 100, 70, 50, or 25? And so think about what you might say. And so if we can try to advance. So it looks like here, so most people said below 70, so 64%. So interesting. Let's touch upon that. So I like that, forward thinking. So we know again in the general population that lower cholesterol is better. This is data from 90,000 individuals. And we know that for every 38.7 milligram reduction in LDL cholesterol, this translates to a 20% reduction in clinical events. And in fact, we know that lowering LDL cholesterol very low using new agents is beneficial. And this is a study looking at PCSK9 inhibitors on top of statin therapy to lower your LDL cholesterol to a median of 21. There was a significant reduction in events. There was not any safety issues. And in fact, the guidelines for the general population now suggest that lower is better with no lower threshold, at least down to 39. And so our group is looking at the impact of lowering cholesterol very low using PCSK9 inhibition in the setting of HIV to look at the impact on non-calcified plaque and arterial inflammation. There are also new agents to lower cholesterol, so bempedoic acid. It inhibits ATP citrate lyase, and it reduces inflammation. It has reduced clinical events in the general population, and along with Judy Courier and Amit Tawakol, we are studying this in HIV. So I think when we think about should we lower cholesterol earlier instead of waiting, this was a study done again in the general population. And I want to point out that the only difference between the two arms was one arm started the lower cholesterol lowering earlier and the other arm waited. And you can see here that doing this earlier translated to a significant reduction in clinical events. And overall, the cardiovascular event rate remained high. I think one thing too to think about the clinical benefit of lowering cholesterol earlier, you can see in this graph, if we do this at age 50, you can see the benefit. However, if we lower cholesterol much earlier in life, like before the age of 50, you can see that this reaps additional clinical benefits. And it's interesting to think if we do this, then will inflammation even be important? And I do want to start to think about the idea of a lifetime risk instead of the 10-year risk, particularly among individuals with HIV infection, with this in mind. And so here in the general population, here are the LDL targets. We know that among individuals who are high risk, the goal is less than 70. It's less than 55 for those at very high risk, as shown here, if you have CKD, diabetes. And if you have recurrent events on statins, it suggests that your LDL should be below 40. Remember that the blood pressure goals could also be lower in high-risk individuals. So, similar to diabetes, statins are now recommended for most persons with HIV age 40 and 75. But I'm going to say that that LDL target in the setting of HIV, whether it should be 70, 55, or lower, remains unknown. So back to our audience response question, I think the answer to this is really unknown, but there's a growing body of evidence that suggests that lower is better for LDL cholesterol. And to that end, lowering LDL earlier may be beneficial. So I want to finish with the role of inflammation in cardiovascular disease. And so back to the right-hand side of this chart. If you look at studies and percent of reduction in LDL cholesterol on the x-axis versus the relative risk reduction, these are all the lipid-lowering studies shown here on diamonds. We now have Reprieve, which fits nicely on this line. However, there are other trials looking at colchicine and canakinumab that don't impact cholesterol, but significantly reduce cardiovascular events. And so with that, I want to think about lowering inflammation in HIV. Will statins do this? And what's interesting, in the data that's been shown to date, inflammatory markers do not seem to be lowered by statins in the REPRIEVE study. And we know that inflammation in HIV extends beyond cardiovascular disease. And so in the general population, there have been many strategies that have advanced to clinical trials. This included low-dose methotrexate, which is very broad immunosuppression. And then kind of on the flip side, a very laser-focused targeted approach, canakinumab, to target innate immunity. And finally, broad immunosuppression with colchicine. So I think seatbelts fasten. I'm going to review a lot of data in the last several minutes, but I'm going to try to take you through it. Okay, in the general population, in the CERT study, low-dose methotrexate did not impact inflammatory markers, and it also did not impact clinical events. We studied low-dose methotrexate in the ACTG 5314 study to show no impact on inflammatory markers either. There was an impact on CD8 T-cell activation, as well as T-cell proliferation among persons with HIV. I also talked about canakinumab. So we talked about statins, which are a little bit downstream in the inflammatory pathway, low-dose methotrexate, which impacts a little bit higher up. And if we go even higher up in the inflammatory pathway, we have IL-1 beta. Canakinumab blocks this molecule, and it's impacted by turbulent flow, hypoxia, and cholesterol crystals. So using an approach to target IL-1 beta in the general population, you can see here there's a significant reduction in inflammation. It did not impact cholesterol. There was a significant reduction in clinical events in the general population. However, due to a complex myriad of reasons, canakinumab did not move forward with regulatory approval. Our group has studied canakinumab in the setting of HIV to show there was significant reduction in inflammatory markers, as shown here, as well as a reduction in both arterial and hematopoietic inflammation, as shown here on the right. So finally, what about colchicine? I mean, it's been around for decades. It's, I think the mechanism is a little bit unclear. So in the general population, Colcott 30 days after MI significantly reduced cardiovascular events. And in the stable population with cardiovascular disease, on top of statin, colchicine significantly reduced clinical events. Now, last month, there was a study that was just published, which confuses the literature a little bit. I'm going to say, based on these two studies, the FDA approved colchicine as the first anti-inflammatory drug to reduce cardiovascular events among individuals who have cardiovascular disease or at risk. But last month, there was a study that looked at colchicine in the setting of acute MI, which did not show a benefit on clinical events. So I think, how this is going to translate broadly remains unknown. Colchicine has been studied in a small study in HIV to show no impact on inflammatory markers. However, this was small and short. So I want to talk, finally, you heard about GLP-1 receptor agonists with Ellen already. And so we know a myriad of benefits, including cardioprotection. It is now recommended regardless of diabetes in the setting of heart failure and coronary disease. So this approach has been studied in HIV, and I think she already reviewed this, so I won't belabor this, showing a benefit in inflammatory markers and liver fat. However, there are some side effects. It is very expensive, and there's high discontinuation rates. So I've gone a little bit over, but in summary, we know from REPRIEVE that there's a benefit from statins in HIV, likely among individuals with a calculated risk of 5% and above. However, there are some individuals with HIV who may benefit. You could consider imaging in those individuals. How will we ensure that individuals with HIV get access to statin and then remain on statin in the long term? Pitavastatin is a moderate intensity statin. Other statins, including atorvastatin and rosuvastatin, could be considered, particularly if there's a cost and access issue. We should always address traditional risk factors like blood pressure, smoking, and diabetes. And I think looking forward into the field, how do we reduce cardiovascular risk? Should we start statin earlier as opposed to waiting till later? Is there going to be a benefit of achieving a very low cholesterol and LDL using different agents? What anti-inflammatory strategies should we use on top of statin to reduce risk? And can we think about imaging again to think about statin decision in persons with HIV, some of them? So here's a nice scientific statement that was published several years ago, and it's a nice resource. And with that, I'd be happy to answer questions. Thank you so much.
Wonderful, Priscilla. Just fantastic review and generated a lot of questions, as you can imagine. So I'll dig right into them. Here's a specific question for somebody who has latent TB, and do you have drug interactions potentially with a lot of the statins? So is it okay to hold the statin for 4 to 9 months? Actually, we're going to be treating mostly for 3 months at this point in time, but I guess you got to do what you got to do. But is there any advice you would have in terms of other medications that might be helpful? I mean, even colchicine.
Yeah, that's a great question. And I think here it's again, it would really depend on the patient. So I think if it's a patient, an individual who has a recent MI or a history of cardiovascular disease, or recent stenting, I don't think that's an individual I'd want to completely stop statin therapy. And it's interesting in the general population, there's some literature that stopping statin therapy is associated with a higher risk of events, particularly among high-risk individuals. So I think if it's someone, it's just primary prevention, they're not high risk. I think you should, of course, you could stop the statin. In a high risk individual, I think I'd consider changing to an agent that has less drug-drug interactions. You could think about, and I hate to say this, but pravastatin, which is a very weak statin, it's renally cleared. I do not believe it has significant drug-drug interactions with the TB medication. I think if it's a very high risk individual and the LDL is high, I actually would even think about injectable lipid lowering. Because it is interesting, we do think that the benefit of statins in HIV seems to be driven mostly by LDL lowering. So if you have another agent that can lower LDL that is in a person that's high risk, that's something I would think about.
Yeah, and my understanding is that pitavastatin has fewer drug-drug interaction. I think you said pravastatin, which does as well, but we could check and see if that has issues with the latent TB drugs, but it may be okay. I need to double check that.
Yeah, that's
yeah. So here's, pulling your whole talk together, which is just very comprehensive and good. There seems to be an effect of statins that goes well beyond the LDL lowering component. That my guess is it has a lot to do with inflammation. So in that regard, do you have any information on the low intensity, moderate, and high intensity statins on inflammation? Does that hold true for inflammation like it does for LDL?
That's such a great question. So I will say in the general population, interestingly, from Jupiter, rosuvastatin had a significant reduction on inflammation, right? Like CRP reduction of like 40%. I think what is interesting and a bit surprising in the HIV field was the pitavastatin, again, from the data that was released to date, significantly reduced LDL cholesterol, but it did not seem to touch inflammatory markers, even using like a proteomics-based approach or using like traditional inflammatory markers. So, whether statins will lower inflammation in HIV, I think remains unknown. And it is interesting in the general population, I will say that the data on which statins lower inflammatory markers the best is still not well developed, which is surprising. Yeah.
It's fascinating because what I remember from Reprieve, and correct me if I get it wrong,
Yeah.
but there was obviously this 35% reduction in all cardiovascular events, but it could not be fully explained by simply the lowering of LDL. And so there was an implication that it might be inflammatory markers, but maybe the marker study didn't reflect the reality of the inflammatory state.
Yeah, so I think in the subset of Reprieve, in which they have published the inflammatory data, 800 patients, it did not seem to touch CRP, IL-6, soluble CD163, markers that we know are very predictive of clinical events in HIV. Now, whether or not that'll be the case in the whole trial, I don't know, but it is surprising that did not that it didn't seem to touch inflammation. I think what's also interesting is that in Reprieve, if you were on a statin, that 40% of the clinical events occurred among individuals who are on statin. So I think to me, that does not mean that statins will be enough to reduce the cardiovascular risk in everyone with HIV, and that additional approaches will be needed.
Yeah. Judith has a great question. We focus a lot on LDL, but what about HDL? There's certainly a large number of people, not large, but there's some people who have, modest LDL levels, but very high HDL, and the calculators don't take that into account directly, if I recall. So what do you say in the status where somebody has an HDL level of close to 100?
Yeah. Yeah, I mean, it's a great point. HDL is very protective, and the calculators do not incorporate that. I think part of that reason is potentially because, we don't have good pharmacologic therapies to raise HDL, despite many individuals trying. So I do think that, having a high HDL should be factored, it's all part of the individual patient, but it is important. So that's a good point.
So Ron has a question about basically abacavir. So we've known about a relative 1.8-fold increase in badness, if you will, from a cardiovascular perspective when abacavir is in a regimen, at least from the cohort studies. And there are some patients who are on abacavir, dolutegravir 3TC, single tablet formulation, and getting them off of that. Do you have any advice or want to review a little bit of the abacavir story? What I'll just tell you, what we've been doing is going to the dolutegravir 3TC and drop the fixed dose and dropping the abacavir, and there doesn't seem to be any antiviral loss there. In other words, activity is similar to the three drugs. So do you recommend getting folks off abacavir at this point?
Yeah, great question. And I think, again, it depends on the individual patient. So if it's a young patient that has, no cardiovascular risk factors, no cardiovascular disease, I think the importance of switching to a non-abacavir regimen is much less critical. If you have an individual, however, who has known cardiovascular disease or is a super high risk, I think I might consider, just given all the controversy, I might consider switching off of it if you have good, alternative regimens, which is
Yeah. And the new guidelines, I think Dr. Gandhi, who's our next speaker, will address this, or I'll be sure to bring it up in the Q&A if he doesn't mention it specifically. Sanjiva has a question about statins effectiveness in different ethnic groups. Has that been studied, at least in the general population?
Great question. Not super studied. I will say there's some interesting kind of there are studies looking at, for example, rosuvastatin in the Asian population, that there's a higher risk of like a rhabdomyolysis, and that's why rosuvastatin, you're not supposed to start, you don't start individuals at 20, you should start at like 5. So there's some like genetic studies looking at the population in particular.
And we found that with different HIV drugs, for example, like efavirenz when it was popular. So here's one of my favorite lines that I use on rounds is that there's a thin line difference between what's dogma and what's dog manure. And so I think the next question is about low dose aspirin. So years ago it was dogma, then it became dog manure. Now it's coming back a little bit. Where do you factor this into patients with HIV who maybe have high cardiovascular risk? Do you use it?
This is a great question. So I think, when I was in training, like everyone got aspirin for primary prevention. Of course, this has fallen out of favor a bit recently. So I think, again, it depends on the risk of the individual, that you're considering. So I will use it among individuals who I feel like have a higher predicted risk and who don't have like contraindications to starting it. So, that's where, so if it's an individual who's older, who has risk factors, I definitely will still use it. But of course, if they don't tolerate it, they have bleeding issues, you know, they're low risk, I think the bang for the buck is much less.
You mentioned using imaging to decide perhaps on starting statins. Use a calcium, the coronary artery calcium score. How would you use that in practice?
Okay, so I'm going to back up the statement a little bit by saying I would say most cardiologists, particularly among asymptomatic individuals, there is not a ton of data on the utility of imaging asymptomatic individuals. However, that being said, I will say in the setting of HIV, if you have a person that you're on the cusp and you're not sure about starting statin or not, that imaging is useful as a means to like tip you over the edge. You could start with a coronary calcium. However, we know that, you know, in some persons with HIV, that the non-calcified plaque is really the predominant form of atherosclerosis. So you could think about like imaging, like carotids, atherosclerosis as well to look for it. And if you have it, I think that is very strong evidence for starting a statin. And I say this because I think, you know, here at UCLA and at UCSF, we've done lots of studies, clinical trials in which we start with imaging. And it's kind of, I would say, surprising how many persons we had with HIV that had evidence of athero on that scan who were asymptomatic. And that's why I think it could be used in select individuals.
And what you just said covered Amy's question here about you have somebody who had ordinarily a low cardiovascular risk score, but had maybe extensive prolonged exposure to high level viremia and low CD4s that the imaging may be differentiating for you.
Yeah.
So I have Rachel says has younger patients living with HIV with high LDLs and some risk factors are elevated. So I guess this means somebody less than 40. How do you estimate risk, and might you pull the trigger a little earlier? I think that graphic you showed with starting earlier and having impact later may talk to this a little bit.
Yeah, I mean, I think it's a very important thing, I think, for us to consider as a field. And I will say it's a little bit of a data-free zone. We know in the general population that likely the lowering cholesterol lower is beneficial. And possibly, I think the thought of doing this earlier as opposed to waiting till, you know, someone is older. In the setting of HIV, we don't really have data on that now, but, you know, extrapolating, it seems like it certainly could be considered. It's again, not on everyone, but if you have a person who's maybe less than 40, but has a strong family history, smoking, or diabetes, that's certainly something that could be considered.
Right. And our last question is digging into the weeds a little deeper on abacavir. So the question is, what is the relative risk of abacavir from your perspective if it is being used currently and then stopping versus ever used, like in the distant past? Does the effect of abacavir persist, or is it more of an immediate risk?
Right, right. From what I do clinically, it's more of a current on it, and not like a history of it. And it's hard to think of, you know, someone being on abacavir like, you know, 10 years ago impacting,
Right.
you know, what's happening today, particularly in the setting of things that are more chronic, like, you know, hypertension, cigarette smoking, lipids, and
Yeah.
HIV disease control. Yeah.
And, and as I think back to the original indication or the signal that there might be an issue here, it was all about the current use of
Yes.
abacavir. And the hypothesis was, and I think still is, that there's an effect on platelet aggregation
Yes.
that is present when abacavir are increased when abacavir is on board, but when you take it away, that effect disappears. And so I think it is more of a current rather than an ever sort of exposure that matters.
That's correct. That's spot on. It is kind of interesting that in that cohort they found a similar signal for integrase inhibitors, that it was kind of with
Yeah,
once and then it went away with time, and what that means, you know?
yeah, I think you did a nice job at the beginning of the lecture to sort of dispel that from the data that you've looked at. Well, this has been a fabulous conversation and presentation. Thank you, Priscilla, for shining a bright light on this complicated topic, but I think the data are helping us sort through this a little more. So we're going to take about a 15-minute or so break. We're going to come back at 1:40 Eastern. That'll give people a chance to stretch their legs and visit the bathroom or whatever they need to do. And we'll come back right at 1:40. There'll be a countdown clock that you can look at that will time it for the reinitiation. We have 2 more talks. Really looking forward to hearing those.